All right, everyone, we're just about to get started with our cardiac rounds this morning. This morning's virtual cardiac rounds will be presented by one of our esteemed colleagues, Dr. Paul Galawango. He will be presenting on treating atrial fibrillation in special populations of patients. Dr. Galawango, it's all yours.
Thank you very much. So good morning, everybody. Welcome to Division Rounds. Today I'm going to be talking about anticoagulation for atrial fibrillation in three distinct populations. So the severely overweight, the elderly, and people with ACS who are not revascularized but rather managed medically. The objectives will be to review the evidence regarding AF anticoagulation in obese patients, review the evidence and recommendations regarding AF anticoagulation in elderly, and also looking at those, again, ACS patients that are not revascularized. These are my disclosures. So first, looking at DOACs in obese individuals, and the sort of the impetus for this talk was a conversation that came up during one of my CCU weeks regarding an obese patient and NOAC therapy, and what are the nuances here that exist. So as we know, DOACs are recommended over warfarin for treatment of non-valvular AF if the CHA₂DS₆65 score is 1 or greater. And this is based on the current 2018 CCS recommendations. Now, the clinical studies that these recommendations are based on didn't tend to have significant representation for obese and especially not severely obese individuals. And just listed here is the table 1 data from the 4 studies in order of their publication. So the first one being RELY, looking at dabigatran, average weight in that study was 83 kilos. In the Rocket AF trial, they actually state the BMI in their table 1, and the average was 28. In Aristotle, the average weight was 82 kilos. And in the ENGAGE study, we're actually not told what the average weight or BMI was. The only mention with respect to weight is that approximately 10% of the study individuals were of low weight, less than 60 kilograms. When talking about obesity, traditionally, when based on BMI, we use a threshold of 30 or greater to indicate someone is obese. Greater than 35, extremely obese, and usually greater than 40 is what people usually consider morbidly obese. And for the morbid obese criteria, sometimes the weight-based criteria of greater than 120 kilograms is used in the literature. So this is sort of the numbers we're talking about. And these kind of patients, again, were not represented to a large degree in the phase 3 studies that the DOAC recommendations are based off of. So what are the considerations one would consider with respect to safety and efficacy of DOACs in these larger individuals? We know that the DOACs use a fixed dosing regimen with no dose adjustment recommendations currently for overweight patients. So they're beautifully easy to use as opposed to warfarin because you don't have to measure drug levels. There's no INR to chase. And we know that the effects of DOACs are closely related to their plasma concentrations, which are related to body distribution volume. So when you're dealing with obese individuals, theoretically, the distribution of volume of drugs can increase with increasing BMI, and this could potentially lead to relative underdosing. And we know that at the extremes of low body weight, we see risk of bleeding increase, which makes sense because serum concentrations, again, would increase as the volume of distribution decreases. So the concern is there a hazard of potentially underdosing when you use standard regimens in obese individuals? Now, the following is phase 1 data. So this preceded the publication of the Aristotle trials. This is phase 1 data looking at apixaban in healthy individuals at the extremes of body weight to get a sense of what the pharmacokinetic and pharmacodynamic impacts were. So in terms of background, again, knowing that extremes of body weight may alter the exposure to anticoagulant and its risk-benefit ratio may be impacted. So this was an open label, single dose study looking at the effective extremes of body weight on the pharmacokinetics and pharmacodynamics, safety, and tolerability of a single 10 milligram dose of apixaban in healthy volunteers. This was a study of 55 participants. The three strata of weight were low weight at less than 50 kilograms, reference weight of 65 to 85, and then high weight greater than 120 kilograms. So these are quite large in this third group. This is what would be classified often as morbidly obese. What they found in this phase 1 study was that compared to the reference body weight group, the mean apixaban concentrations, as well as the area under the curve, were 27 and 20% higher respectively in the low body weight group. And conversely, in the high body weight group, the mean concentration and area under the curve for apixaban was 31 and 23% lower respectively. Furthermore, the elimination half-life was approximately 3 hours shorter in the high body weight group and approximately 4 hours greater in the low body weight group. So hanging around longer in the smallest individuals and quick, shorter half-life, eliminated faster in the morbidly obese arm. In this graphic here, you can see on the left, plasma concentration versus time. So the blue dots is the reference group. The orange dot is the low body weight individuals. Purple is the high weight, and you see the trend towards the highest concentrations in the low body weight individuals with the lowest concentrations in the high BMI group. Now, if you look at the right graph of the relationship between the apixaban concentration and anti-10A activity, there was a direct linear relationship between concentrations and anti-10A activity that was consistent across the body weight spectrum. So from this small phase 1 study, the authors felt that the extremes of body weight on apixaban exposure were considered modest and not likely to be clinically meaningful. And again, they did note that the anti-factor 10A activity showed a direct linear relationship with apixaban concentrations, regardless of body weight, and that the apixaban was well tolerated by all participants, including those at the extremes of body weight. And the recommendation there was that, based on this, was that no dose adjustment recommendation for apixaban based on body weight alone. However, a caution is warranted in the presence of additional parameters such as renal insufficiency that could increase apixaban exposure. And this was a study that came out in 2013. Now, ultimately, the phase 3 study that led to the definitive recommendation of apixaban over warfarin on the basis of superior safety and efficacy was Aristotle, and that was published in the New England Journal of Medicine. Now, following the publication of Aristotle, there was a post hoc sub-analysis looking at extremes of body weight in participants in this study, and this was published in Circulation. So the objectives of this post hoc analysis was to determine the efficacy and safety of NOACs for stroke prevention in patients with non-viable AFib randomized with apixaban versus warfarin according to body weight. And in this arm, in this group, they had 3 strata. So low weight, less than 60 kg, mid-range, so 60 to 120, and high weight 120, which again is quite large and what the literature often would categorize as morbidly obese. Furthermore, in the highest weight group, they did a sensitivity analysis, subdividing them into those of 120 to 140, and then at the highest range, greater than 140 kilograms. And this is just the flow diagram. And the vast majority of patients in Aristotle did have a baseline weight recorded. So about 99.7% of the population was included in this post hoc analysis. So the vast majority fell into the mid-weight range, about 83.6%. Low weight was just under 11%. And morbidly obese, so high weight, was a small proportion, 5.4% of the study of participants. What they found was when you looked at the different metrics for efficacy and safety and observed them for an interaction with weight, no significant interaction was noted. So the main effects that were seen in the Aristotle study were preserved when you looked across the spectrum of weight without any significant sign of influence. So whether that be stroke or systemic embolism, all-cause mortality, MI, the benefits of apixaban over warfarin were preserved. And the one caveat was they did actually see significant weight interaction when they looked at major bleeding with a favorability for apixaban that was even more significant, statistically so, at the extremes of lower weight. So those low weight individuals, as well as the lower end of the normal group, had a statistically significant interaction with weight, showing benefit in terms of less bleeding with apixaban compared to warfarin. So the conclusion was that from the Aristotle study, apixaban appeared to be efficacious and well tolerated across the spectrum of weight, including low and high weight individuals. And the superiority on efficacy and safety compared to warfarin persisted across the weight groups, with an even greater reduction in major bleeding in those with low and normal weight as compared to the high weight individuals. Now, what about other centers, and what have they seen with different NOACs versus warfarin in the morbidly obese? This study that was published in 2019 was a single center study that was retrospective in design, looking at the efficacy and safety of DOACs and warfarin in morbidly obese patients with AFib or AFlutter. Single center retrospective study from 2012 to 2016, with the primary efficacy outcome being incidence of stroke or TIA, and the primary safety outcome being major bleeding. These were patients who were all 18 or older, BMIs of greater than 40 or weights of greater than 120, that were taking either warfarin, dabigatran, rivaroxaban, or apixaban for AFib or atrial flutter for at least a month. You can see the exclusions there as well. A relatively small study, so you had 64 patients in the DOAC arm and 64 patients in the warfarin arm. In terms of the DOACs, the most frequent was rivaroxaban at just under 40%, followed by dabigatran at 31%, and then apixaban at just under 30%. And again, what one would be concerned here is potentially increased risk of thrombotic or ischemic stroke in the DOAC arm with these large body habitus individuals. The data from the scatter plot and from the statistical analysis didn't show that, so there was no significant difference between DOACs and warfarin for any of the reported outcomes. And you can see that on the scatter plot, the trend is towards favoring DOACs, with the exception of pure stroke, where it looks like a slight trend in favor of the warfarin. But overall, no statistical difference amongst any of these outcomes. And again, we are dealing with small numbers here. In terms of looking at the individual DOACs, the study was really not powered to look at differences between the three different agents, although you do note that there were 2 life-threatening bleeds seen in the dabigatran arm, but again, small number of patients. So from this small retrospective study, the authors conclude that DOACs were not associated with increased stroke or TIA event rates in these morbidly obese patients compared with warfarin. The study results, the authors felt that favored that DOACs, except for dabigatran, may be considered as an alternative to warfarin for AFib in patients who are morbidly obese. And dabigatran needs caution in further studies to evaluate it, again, because of those 2 life-threatening bleeds seen in the dabigatran arm. But again, larger retrospective or ideally prospective studies would be needed to confirm these findings. Another study published in 2019, so this was a multi-center study looking at body mass index on safety and efficacy of direct oral anticoagulants, again, retrospective in design. Aim of this study was to look at the thrombotic or bleeding events in admitted patients to determine if those with a higher BMI were at higher risk for an index event. This was a retrospective study done in the Midwestern health system in the States that included nine hospitals. Their outcomes of interest were the rates of thrombotic events and overt bleeding events stratified by BMI. So these were all patients that were admitted to one of the hospitals in this network that were on the DOAC prior to admission. And you can see the exclusion criteria there as well. And so in terms of the strata here, the tier 1 was patients who were not obese, so BMI less than 30. So, broad, quite a large sort of umbrella under that, but, you could be underweight, you were normal weight, but as long as you weren't obese, your BMI is less than 30, you were in tier 1, that was your comparator. Tier 2 was BMI 30 to 40, and tier 3 was morbidly obese, so BMI greater than 40. What they found here is, so in the green is your overt bleeding events, in the blue is your thrombotic events. Overall, the incidence of these adverse events were low. Okay, that's the first thing for all strata. So they were low incidence of these adverse events, and there was no statistically significant difference amongst the three strata. Trends were seen, but no significant difference. And this graph is quite compressed here. So this is just looking at incidence occurrence rates of between 0 and 3%, just to help illustrate the trends. But again, no statistical difference. What you're seeing is in terms of bleeding events, in the reference cohort, so the smallest individuals, BMI less than 30, you had a trend for the highest rates of bleeding, and then stepwise going down as you got to heavier individuals. And with the heaviest group, the morbidly obese, the BMI greater than 40, they had the highest incidence of thrombotic events, so 1.5%. But again, no statistical significance compared to your comparator group, where it was 1.3%. So the authors conclude that among these patients admitted to this single health system on DOAC therapy, obesity did not significantly correlate with thrombotic or overt bleeding complications. Okay, and important trends, though, that were identified was that the group of patients with the BMI greater than 40 was the only one that had a higher thrombotic occurrence compared to bleeding rate. And the smallest body size group had the highest occurrent rate of bleeding events as well. But again, overall, no statistical difference among the three arms. Now, the International Society of Thrombosis and Hemostasis put out a statement in 2019 stating that the evidence from pivotal trials of DOACs suggests that the current dosing is safe and efficacious in obese patients. However, there is a caveat there in terms of the extremes of weight. So due to small cohorts, further investigation is required for those weighing greater than 120 kilograms or having a BMI greater than 40. And if DOAC therapy is desired in these morbidly obese individuals, peak and trough drug-specific levels should be drawn in accordance with ISTH guidelines until there's further conclusive evidence. And so that's not something that I've ever seen done clinically on the wards, although we don't run into patients of this size that frequently, but on occasion we do. And so I think important just to know that the current recommendations are that if we're going to use DOACs in these individuals, we should actually be getting confirmation of peak and drug levels to make sure that we're safely anticoagulating them. And this was a interesting article that's worth taking a look at, published in JACC in 2014. It was a systematic review looking at lab measurements of anticoagulant activities for DOACs, so sort of another way one might be able to get a sense of whether you're achieving therapeutic range or not, if you're not able to get quick access to peak and trough drug levels. And so this table sort of summarizes what they found, and it's useful to take a look at. So, with the bigatran, although it's one that we don't use that much these days anymore, but if you want to get a sense of if you've got, clinically relevant drug levels or therapeutic levels on board, the test they recommend is looking at the thrombin time. because if it's normal, it pretty much excludes clinically relevant drug levels. So if you have a normal thrombin time with a bigger trend, you're unlikely to be at therapeutic levels. With rivaroxaban and with apixaban, the suggested test to use is the anti-10A activity, because normal anti-10A activity likely excludes clinically relevant drug levels. So if your anti-10A activity is not elevated, it's unlikely you're at therapeutic dosing for these agents, and it could be helpful as a quick screen if you're using them on an obese or morbidly obese individual. For rivaroxaban, we know that it does raise the prothrombin time, so it'll prolong PT, but a PT is not sensitive enough to rule out significant levels. So a normal prothrombin time doesn't rule out clinically significant levels, and that's why they recommend using anti-10A activity. Related also with apixaban, it will raise your PT and PTT, but again, they are not sufficiently sensitive enough to exclude apixaban activity. So even if those levels are normal, it doesn't exclude a therapeutic dose. So you're actually better off to use anti-10A levels if you want to get a sense. Now, what about age? We know that age is strongly correlated to risk of stroke, and AFib across the board confers about a 5-fold increased risk of stroke. But in patients of 80 years or older, AFib is linked to as many as 1 in every 3 strokes. And in approximately 2/3 of patients of 80 years or older with a stroke, this is going to result in death or disability. So this is obviously exquisitely a high-risk group in terms of incidence of stroke and morbidity and mortality from stroke if one is to occur. So a group that we do want to be aggressive in trying to reduce the incidence of this adverse event. But we know also that there sometimes can be a tendency to undertreatment of anticoagulation in these older patients because of risk of frailty. So underuse of oral anticoagulation AFib is one of the most common examples of unadopted prescription in elderly individuals. In individuals of 80 years or older with non-valvular AFib, 54 studies on warfarin therapy estimated the prevalence of underprescription to be about 40%. And in other studies, they've seen that in less than 50% of eligible elderly nursing home residents was anticoagulation prescribed, despite them being at high risk for stroke. One study looking at patients admitted on a geriatric service between 2008 and 2010 found that 50% of the population did not receive any anticoagulation, despite a clear indication, regardless of their individual bleeding or stroke risk. Now, there are many reasons cited for underuse of oral anticoagulant therapy in older patients, including advanced age and short life expectancy, concern about risk of bleeding, concern that the risk-benefit ratio may be skewed more towards risk, poor baseline health, and concerns about geriatric syndromes, especially falls. And you can see in this table some of the criteria that associated with prescribers withholding anticoagulation, and the leading one is falls, and after that, cognitive impairment. Looking at Canadian data, so from Canadian long-term care home experience, also we found anticoagulation underuse in atrial fibrillation. So this is a retrospective review in 2015, including residents of greater than 65 years with a diagnosis of AFib in long-term care facilities, identified 433 residents in these long-term care facilities with atrial fibrillation. The average age was 87. The mean CHAD score was 3. And as not surprising, there was quite a bit of polypharmacy in these patients. So 90% of them were on 10 or more medications. What they found was that 37% of these patients were on no antithrombotics, so no oral anticoagulant or anticoagulant therapy. And this was despite them being candidates for anticoagulant stroke prevention based on their risk profile. Now they tried to see what was the reason for the care gap. So was it advanced directives, saying do not go to hospital? Was it DNR orders with dementia? Was it cognitive scale? Was it activities of daily living, a self-performance scale? But none of these factors were found to correlate significantly with failure to prescribe oral anticoagulant therapy. So when they explored it to tease out what were the reasons for underuse, they found that there were significant knowledge gaps about stroke risk and extent and anticoagulant risk-benefit harm ratio, lack of recognition of expanded eligibility for oral anticoagulants and DOACs in the elderly, and concern about bleeding risk with DOACs. So this is where I want to discuss this group called the FORTA group, which is a group based out of Europe, and FORTA stands for Fit for the Age. So this is a body of experts that come out with expert consensus recommendations for medications specifically for treatment of the geriatric population. And they publish consistently different recommendations looking at different medications in terms of their suitability and risk-benefit ratio for geriatric individuals. So their classifications are meant to assist clinicians in balancing the risk of multimorbidity and polypharmacy. And the FORTA recommendations are proven effective as clinical tool, and they're quick and user-friendly and useful when treating elderly patients, and they contain both negative and positive recommendations for medications. Their assessments are based on review of the best available data, and again, they are published periodically and with different medications in the different consensus guidelines. And so the recommendations are letter-based with a class A indicating absolutely they should be given. These are indispensable drugs with clear-cut benefit in terms of efficacy safety ratio in the elderly. Class B is the next best, so beneficial, so proven or obvious efficacy in the elderly, but limited extent of effect or safety, with limited effect or safety concerns. Class C there's some caution there, be careful, questionable efficacy safety ratio. And then Class D is definitely avoid, so do not use in the elderly. And these are some of the considerations that the FORTA group is looking at with respect to older patients and the changes in pharmacokinetics and pharmacodynamics that are relevant when looking at various medications. So changes in gastric acidity that affect absorption, reduced carrier-mediated permeability, reduced first-pass metabolism, reduced hepatic blood flow by up to 50%, which may affect clearance of drugs, reduced phase 1 metabolizing capacity, and then reduced renal function, which again may affect elimination of drugs and cause hazard. So in 2019, the FORTA group took aim at looking at the issue of oral anticoagulants for long-term treatment of AFib in older patients. And these recommendations were actually published in 2020. So this is the most recent FORTA review for this particular issue. So in terms of conducting this review, you had geriatricians as well as cardiologists with a lot of experience in pharmacotherapy and older people, tended to be academic physicians with prominent standing either in the field of geriatrics or cardiology. And from this pool came this experts panel that conducted the review from multiple different countries. They did an extensive literature review. They ended up looking at pulling out 202 abstracts, and from there they looked at potentially 72 papers that could be instructive. And out of that, ultimately the ones that were felt to be of significant robustness and quality ended up being 11 papers that contain results on clinical trials on older patients or explicitly reported data from older patient subgroups in their studies. And based on that review of these highest quality trials, looking specifically at the effects of anticoagulations for AFib in the elderly, came the 2019 recommendations. First, looking at vitamin K antagonists. So the top three here are ones I'd never heard of. We don't tend to use, and they got a Class C recommendation. The one that's relevant to us, of course, warfarin received a Class B recommendation from the FORTA group for use in the elderly. And then with respect to DOACs, apixaban got a Class A recommendation, so the highest support. And the other DOACs received a Class B recommendation, so also supported for use in the elderly, but slightly lower degree of support than apixaban. But all received a sort of thumbs up from the FORTA group for use in the elderly. And this is summarized here in this graphic. So Class 1A, absolutely, saying indispensable drug, clear-cut benefit. Apixaban, Class B, so beneficial with proven or obvious efficacy in the elderly, but limited extent of effect or safety concerns, are rivaroxaban, dabigatran, edoxaban, as well as warfarin. So it gives us, I think, some comfort or reassurance that especially the commonly used DOACs, can appropriately be used in the elderly. And especially, it seems like apixaban is a safe and effective choice for AFib in the elderly population based on this consensus review. So the FORTA 2019 confirms that AFib can be successfully treated with positively labeled oral anticoagulants in the older age. Emerging evidence underlines that this recommendation seems to be valid even in patients with geriatric syndromes, in particular falls. And more studies, the panel cites, especially aimed at this frail or vulnerable section of an aging population, are urgently needed. As we know, in a lot of clinical trials, the participants there are younger and healthier than a lot of people we actually see in real life clinical practice. So these FORTA recommendations are useful when looking at the geriatric cohort. Now, what about antithrombotic therapy in AFib and patients with ACS? In particularly, what I wanted to explore was those ACS patients who are not being revascularized but managed medically. What does the evidence say in terms of safety of DOACs over warfarin in this population of patients, which again, not uncommonly seen, and often in older individuals, we manage it conservatively as opposed to use an invasive approach. So in terms of background, optimal antithrombotic regimen for patients with AFib who have an acute coronary syndrome or require PCI was unclear. Prior studies looked at strategies to reduce bleeding associated with triple therapy. So first was the West study, where they saw less bleeding and fewer ischemic events without aspirin compared with warfarin and dual antiplatelet therapy. And then the Pioneer AF-PCI study showed that you had less bleeding with 2 reduced dose rivaroxaban regimens compared with warfarin plus dual antiplatelet therapy. And then the Redual PCI study showed less bleeding with 2 standard dose dabigatran regimens without aspirin compared with warfarin and dual antiplatelet therapy. On that background came the Augustus trial, looking at AFib patients with either recent ACS or going for elective PCI. And they found that apixaban use without aspirin resulted in less bleeding, fewer hospitalizations, no significant difference in ischemic events than regimens that included warfarin, aspirin, or both. Now, safety and efficacy of the antithrombotic regimens might differ between patients with AF who have ACS treated medically or with PCI and those undergoing elective PCI. So as part of their pre-specified analysis, they stratified, looking at those patients who had ACS treated medically. So this is the ACS medical arm. Patients with ACS treated with PCI, and then patients undergoing elective PCI in a non-ACS setting. Note that in a 2x2 design, apixaban was compared with warfarin and aspirin apixaban compared with warfarin and aspirin compared with placebo in patients with AFib who had ACF or undergoing PCI and receiving a P2Y12 inhibitor. This is a schematic of the trial design, which I think we're familiar with now. So of the randomized patients, their randomized initial tier was apixaban versus warfarin. And then additional level of randomization was at the antiplatelet level, aspirin versus placebo. And then the ACS or PCI patients all had a planned P2Y12 inhibitor for at least 6 months. Primary outcome for the study was major or clinically relevant non-major bleeding. Secondary outcomes were death or hospitalization, and then death or ischemic events. And in this schematic, you see that in the ACS arm, it's stratified into ACS PCI versus ACS medical, which is a group that I'm wondering about in terms of warfarin versus DOAC. And so this again shows that for the apixaban versus warfarin, the percentage of ACS medical, you had about 23% that were managed medically, and then ACS with PCI 38%, and elective PCI about 38%. And what you see is that the primary endpoint showing superiority of the DOACs or apixaban over warfarin showed consistency across the 3 arms. So elective PCI, ACS PCI, and ACS medical. This is also seen in the antiplatelet cohort as well, looking at the event rate for placebo versus aspirin, where there seemed to be a demonstration of increased hazard of aspirin versus placebo. So the conclusion from the study is that the overall results of the Augustus trial were consistent across the 3 clinically important subgroups: elective PCI, ACS PCI, as well as ACS medical. So accordingly, anticoagulation with apixaban at the approved doses for stroke prevention in patients with AFib combined with a P2Y12 inhibitor without aspirin should be preferred in patients with AFib and ACS, irrespective of management with either medical therapy alone or PCI, or those undergoing elective PCI. This is a study that came out in the New England Journal 2019, looking at AFib and stable CAD, so the non-ACS setting. And this was a study looking at rivaroxaban. This was the AFIRE trial. I think it's actually a study that came published out of Japan. So this was 2,200 AFib patients that were either stented more than a year ago or with CAD that was managed medically, so without Revasc. And they were randomized to rivaroxaban alone versus rivaroxaban and antiplatelet. And the study was actually stopped early because of excess mortality in the combination arm, so the riva plus antiplatelet. And based on this study, the recommendation was that monotherapy arm was not inferior to combination therapy for efficacy, so stroke, MI, unstable angina, death. And based on this study, it sort of reinforces the fact that for stable AFib CAD patients, so in the non-acute coronary setting syndrome, NOAC alone is appropriate and actually preferred over combination of NOAC and antiplatelet. And so this is illustrated and mirrored in the ESC guideline that you see from 2015, showing the recommendations that for in non-revasc patients, so medically managed or bypass patients with AFib, and dual therapy, so anticoagulant plus antiplatelet, single antiplatelet, and then after 12 months, lifelong monotherapy, so antiplatelet alone. And then for PCI patients, again, after 12 months, monotherapy with anticoagulant alone. And so to conclude, from reviewing what literature exists for these three unique populations, seems that for obese individuals, there's no conclusive evidence of hazard with DOACs in comparison to warfarin. However, the data is limited, but we see that the ISTH does recommend drawing peak and trough levels for morbidly obese individuals where the BMI is greater than 40 or the weight is greater than 120. And from that, the JACC systematic review, we also see that another useful lab measure can be looking at the anti-10A activity if you're on rivaroxaban or apixaban, because if that is normal, then it's very unlikely that you've got clinically relevant drug levels on board and the patient may be underdosed. For the elderly, appropriate anticoagulation is often withheld due to concerns about risk-benefit ratio and frailty, but consensus recommendations from the Forder Group 2019 statement do actually recommend that anticoagulants can be safely used, and apixaban receives a Class A recommendation, with rivaroxaban and dabigatran, as well as warfarin, receiving Class B recommendations. And finally, for those ACS patients who are medically managed with AFib, they too derive benefit of DOACs over vitamin K antagonists. But once they're felt to be out of the acute period, antiplatelets should be stopped. Typically, this is after 1 year. And this was also mirrored in the a-Fiori trial, showing excess harm if antiplatelets were maintained after 1 year. So I will thank you for your attention and happy to take any questions.
Thank you, Dr. Gallo-Wango, for presenting this morning. We'll move into the question and answer period. Just remind everyone that you can either type into the question and answer box on the right-hand corner, or you can use the raise your hand function, and we'll keep it open for a couple of minutes. Dr. Ritchie, I believe you have your hand up. Can you hear me, Dr. Ritchie? He might be having difficulty with his microphone.
Joe, are you on mute?
I believe he has his microphone on. We'll give it a couple of minutes.
Okay.
Dr. Ritchie, if you can hear, so you can't use your microphone, you can always type into the chat box and I can say it to Dr. Gallo-Wango. Looks like he's calling you.
Yeah. Hi, Joe.
We'll leave it open for a couple of minutes.
I'm most concerned about stent thrombosis. Is there any evidence that it's increased without the use of dual line platelet therapy?
Sure. So your question is there evidence that stent thrombosis is increased for which population? Oh, sorry, I lost Joe. But I think Joe was asking, was there any evidence? Oh, it's calling again. Okay. Hi, Joe. Sorry, you're asking about stent thrombosis in which setting?
In the groups with line platelet therapy, the angioplasty have always been highly focused on stent thrombosis. Is there any evidence not a signal if that occurs, or is it just an overstated risk? The dual line platelet there is often driven by early hazard related to early stent thrombosis, right? There's a lot of benefits related to that, but there's no signal for that in any of the anticoagulant versus.
Gotcha. So the question from Joe was is there any evidence that there's increased risk of stent thrombosis in the DOAC plus P2Y12 arm compared to the triple therapy arm, because that's obviously the biggest concern, and so not that I saw in the studies, and I know in the and practically in the CC, we typically will still do triple therapy for 2 to 4 weeks, just to sort of mitigate against the risk for early stent thrombosis. But I can't say that I was able to find a signal for increased risk in the DOAC plus P2Y12 arm versus the triple therapy arm. I don't know if there are any interventionalists on board that have any more insight into that, but it doesn't seem to be something that's been seen in the literature. And that's why I think we safely use P2Y12 plus DOAC and excluding aspirin to reduce the risk of bleeding hazard.
All righty. I think we'll conclude it here. If anyone else have any questions, you can always email Dr. Galawango. And I just want to thank you, Dr. Galawango, for this morning's talk, and have a good rest of the day, everyone. And we'll see you next week.
Thank you. Thanks a lot.